Hello to everybody. I'm Dr. Robba from Genova, Italy, and we are going to discuss in the next 15-20 minutes about the mechanical ventilation in brain injured patients. Um, this is the agenda for the next minutes that we will spend together. As you can see, we will start discussing the pathophysiology, the clinical evidence then, and then we will have some time to discuss the mechanical ventilation strategies in real life, the ongoing research, and a bit of research agenda for the next year on this topic. So experimental evidence, it is pretty clear from both experimental and clinical evidence that there is a lung and brain crosstalk. And in particular, actually, it's not just a brain-lung crosstalk, it's a systemic and brain crosstalk, because every time there is a brain injury, there is also a dysfunction or anyway an effect on the peripheral system, which includes, for example, liver failure, kidney failure, infections, pituitary dysfunction, cardiological and respiratory complications. And in particular, when there is a initial cerebral damage, what happens is that this is a normal healthy brain with the astrocyte and the microglia here. And when we are in front of an injured patient, there is a disruption of a tight junction with infiltration of the macrophage, of the microglia and lymphocytes at the level of the brain, and loss of protection between the brain and the vascular system. And this causes a local inflammation, which then becomes a systemic inflammation. And this happens through different mechanisms, which the main ones are the vagal cholinergic reflex and the sympathetic reflex. And this causes systemic inflammation with activation of the cytokines, of the interleukins, endothelial cell injury with lung inflammation, and therefore the occurrence of lung injury. Also, our therapies can be detrimental for both the brain and the injury. In fact, when we treat the brain, when we treat, for example, intracranial hypertension, we can use drugs like the barbiturates, we can give the patients hypothermia, we can cause hypertension and hypervolemia, and these can further damage acute lung injury. And per se, brain injured patients are patients who have a higher risk of pulmonary complications such as pneumonia, VAP, neurogenic pulmonary edema, thoracic trauma, etc. So it's a sort of very difficult and complicated situation. This is an experimental and interesting study which was performed on piglet models here, who were monitored with intracranial pressure, and this is basically a model of acute intracranial hypertension. And what the Hoyer and colleagues found in this study is that intracranial hypertension can per se increase the quantity and the amount of extravascular water at the level of the lung, and that really per se can further damage brain function. The patients, the experimental models were divided in 4 groups: the control, patients with acute intracranial hypertension, experimental models with ARDS, and with acute intracranial hypertension. And as you can see here, in both the control and ARDS patients, the occurrence of intracranial hypertension was associated with an increase of the water in the chest. So per se, without any external causes, the occurrence, experimental induced, of intracranial hypertension cause lung damage. And on the other hand, in the group of ARDS, the occurrence and the presence of experimental ARDS was associated with an increase of NAC, which is a marker which is associated with a brain dysfunction and neuronal damage, and this was independent for the occurrence of intracranial hypertension. So important crosstalk, and this means that when we have a brain damage with a lung damage, we are really in trouble from a clinical point of view. Clinically speaking, we are in trouble because when peripheral organ dysfunction occurs after brain injury, the patients have a worse outcome, a very important increase of bad and poor neurological outcome, and an increase of a mortality. And in particular, the occurrence of pulmonary complications like ARDS is associated with an increase of mechanical ventilation days and ICU mortality and hospital mortality. Is it common? Well, this is a study that we have just published on neurocritical care just a few months ago. And we found that actually the occurrence of ARDS in subarachnoidal hemorrhage patients is not that common, at least is not as common as it used to be in previous evidence. We will discuss this in the next minutes. However, when it occurs, it is strongly associated with poor neurological outcome and mortality. And this is important because the presence of lung injury per se is associated with an increased mortality in patients with traumatic brain injury. And as you can see here, it is also associated with cerebral hypoxia. Cerebral hypoxia and systemic hypoxia are strongly correlated because there is a linear relationship between them. But if you can see the results from this physiological study that we performed with a group of Cambridge, when the PF is below 300, already there is a damage in terms of cerebral oxygenation. And the problem is that the concept and the threshold of at-risk cerebral oxygenation, it strongly depends by age, because, for example, in subjects which are younger, they can probably tolerate a lower threshold of PbTO2, of cerebral oxygenation, but in elderly patients, probably we need to increase even more the need for oxygen to the brain. And this is an important point, because this means that we need to neuromonitor the patients to individualize our treatment. Which is the state of the art? So the concept of protective lung ventilation has been established in ARDS patients, but which is the state of the art in non-ARDS patients, at least at the beginning, the first phase. This is one study, a randomized controlled trial of the PREVENT investigators, which compared tidal volume of 6 versus a tidal volume of 9 millimeter per kilo of predicted body weight, with a primary endpoints, which was ventilatory free days and mechanical ventilation days. So when we compare a low versus intermediate tidal volume strategy in patients without ARDS, there are no differences in terms of primary and secondary endpoints. So regarding ventilatory free days and days of mechanical ventilation, it doesn't really make any difference, as you can see here from this graph on the right. However, in the group with low tidal volume, the authors found higher frequencies of hypercapnia, of course, which was correlated with a longer mechanical ventilation days when the patients were intubated in the ICU, and a higher incidence of delirium. So be careful anyway to the hypercapnia or to the pH is maintained. Regarding the PEEP is still an open question probably, but this is a nice systematic review and meta-analysis of a randomized controlled trial which compared the low PEEP levels with high PEEP levels here. And as you can see from the pooled results, the use of high PEEP with these levels had no effect on the duration of mechanical ventilation, but it was probably related to a lower rate of ARDS. We are still talking about patients with initial no ARDS, so like a general brain injury patients. What we know in non-ARDS patients is that we need to be protective in terms of intrathoracic pressure. So the driving pressure, for example, is something that we need to keep in our mind. As long as we keep the driving pressure below a certain threshold, which is generally 15 centimeters of water, we reduce hospital mortality. But there is a linear correlation with the increase of driving pressure and hospital mortality. And the same is basically for the plateau pressure. So in both ARDS and non-ARDS patients, we need to be protective and keep a plateau pressure below a certain threshold in order to reduce the VILI and to reduce further lung injury. Which is the problem of applying this concept in brain injured patients? The problem is that brain injured patients have specific characteristics, and there are also concerns regarding the use of the protective ventilation and rescue strategies in these patients, because if we use low tidal volume, for example, this can cause hypercapnia, and this can increase intracranial pressure, and we don't want an increase of intracranial pressure in brain injured patients. On the other hand, the use of high PEEP or increased intrathoracic pressure, for example, for recruitment maneuvers or prone position, etc., can increase the intracranial pressure consequent to increased intrathoracic pressure. And this is, again, something that we don't want. So traditionally, brain-injured patients have been considered a different group of patients in terms of principles of mechanical ventilation. And there have been a number of false beliefs, I like to call them, because now we are trying to make a more deep reasoning on this. But these patients were ventilated with ZIP, so with no PEEP. They were ventilated with very, very high tidal volume, like 10 milliliter per predicted body weight. These were patients where prone position, recruitment maneuvers, ECMO, and all the rescue strategies were completely forbidden and were not considered at all. And these patients have been considered excluded from the big trials where lung protective strategies have been tested, because the presence of acute brain injury was considered a contraindication for the use of lung protective ventilation. And in fact, when we are in front of both acute brain injury and lung injury, we are really in trouble, because we don't have any recommendation, we don't have any real randomized controlled trial, we don't have any evidence. And if you see the targets and the use of different recommendations for different rescue therapies and ventilatory strategies, sometimes the recommendation for the brain are exactly in the opposite way of those of the lungs. And even the respiratory targets, like the target of oxygenation and the targets of for the lung, are not really going in the same direction. For example, for the ERDS, a 55, 80 millimeters of mercury of oxygen is probably enough. But if you have an acute brain injury, probably you have to keep your oxygenation higher than this. So what we should do when we are in front of a brain and lung injury? Well, what we know is that anyway, even in brain injured patients, the driving pressure and the protective strategies associated with low intrathoracic pressure are anyway useful. This is one of the few studies exploring the role of ventilator parameters and strategies in brain injured patients. And what they found here in this paper is that driving pressure is associated with the development of ARDS in a mechanically ventilated brain injured patients. So try anyway to be protective with, regarding the pressure. For the rest, we really don't have much evidence. But in the last years, we worked a bit asking to the physicians and to the expert, which is basically the state of the art. So in real life, what do neurointensivists do in terms of mechanical ventilation? This is a survey which was published like last year on critical care from the European Society of Intensive Care, and the respondents were asked to reply to several questions regarding the ventilator settings in 3 different scenarios: in patients with a PF above 300, between 150 and 300, and below 150. And as you can see from the results, the general idea that we got from this survey is that people are starting not to be so strict in the old false beliefs regarding brain injured patients. So brain injured patients are starting to be ventilated in a protective way with a low intermediate tidal volume, and that the people are not scared anymore about using high PEEP even in the presence of intracranial pressure, of course, if this is needed. And there is also another signal from this survey, which is that even the recruitment maneuvers, the prone position, and also the ECMO and the extracorporeal circuits are rescue strategies which at least should be taken in consideration and that are actually used. So see that they are not contraindicated anymore. This is what happens in the operating room. This is a secondary analysis from the Las Vegas study, which is a large observational study. And as you can see here, there are the ventilatory settings that are generally used in neurosurgical patients with brain damage. So if you have a look here, the tidal volume that was generally used was 8 milliliters per kilo predicted body weight, and no one of the responders of these centers use a ZIP anymore. And if you look at these scatter plots, where we considered the different ventilatory settings of PEEP, peak pressure, respiratory rate, and driving pressure in brain-injured patients and non-brain injured patients, the ventilatory settings were basically not different in terms of intrathoracic pressure and respiratory rate between brain and non-brain injured patients. So it seems that in neurosurgery, brain-injured patients are starting to be ventilated basically in the same way as in non-brain injured patients. What's happening in the ICU? This is an interesting paper which is going to come out on critical care medicine soon, including 3 different cohorts from 2004, 2010, and 2016. And what we analyzed were the changes in the ventilatory settings among these 3 cohorts. This is the tidal volume, for example. As you can see, over the years, there is a reduction of the tidal volume used in brain-injured patients. In 2004, there was a large number, 30% of patients who used more than 10 milliliter per kilogram of predicted body weight, and these are much lower now, and protective ventilation is gaining definitely more interest. And the same is for PEEP. Increasing PEEP are being used over the years, but the interesting thing is that in 2004, still a lot of people used less than 5 centimeters of water of PEEP, and now just really a small number of brain-injured patients in the ICU are ventilated with less than 5 centimeters of water of PEEP, and nearly no one with 0 of PEEP. And then we try to move forward, and we asked to the expert, the world expert, what do they do and what do they recommend in terms of mechanical ventilator settings. So we have created a panel of 29 experts from all over the world, and through a Delphi approach, we basically tried to give some recommendations. I have to tell you already that unfortunately there are no evidence, have a look here, in nearly no one of the demands that we try to address. And there is also a bit of lack of consensus on some important topics. But in some other, I think we can have some clinical information that could be interesting. So the first demand that we asked to the expert was regarding the indication of endotracheal intubation. And a strong recommendation was obtained regarding the indication for intubation. We should be guided from different factors, so a combination of factors, both respiratory factors and neurological factors, basically to protect the airway. The suggestion of the expert is not to weigh too much, because brain-injured patients need a strict oxygen and carbon dioxide control, so don't weigh too much for the intubation. It is unclear whether the use of non-invasive ventilation can be safe and effective. Maybe for the NIV, we still didn't get any recommendation, but we obtained a recommendation even 2 weeks regarding the use of high flow cannula oxygen, which can be actually considered a good option in acute brain injured patients. Regarding the ventilatory settings, we obtained a strong recommendation regarding the concept of PEEP, and basically the expert agreed that we should use the same level of PEEP that we generally would use in the general ICU population, and that if there are not important contraindications in terms of intracranial pressure, we still should use lung protective ventilation strategies such as low intermediate tidal volume and low plateau pressure and low driving pressure. However, when ICP is unstable, things are obviously a bit more difficult, and in these cases, when significant ICP elevation occurs, we did not find any consensus, and I think this is a very crucial point for future research. Target of oxygen. The target of oxygen for brain-injured patients is higher than in those recommended for ARDS, so try to keep them between 80 and 120 of oxygen and aim to normocapnia. In case of brain herniation, consider the use of hyperventilation as therapeutic option. In case of intracranial hypertension, we did not obtain the consensus, but there are some other consensus and guidelines which suggest a mild use of hyperventilation and hypercapnia around 30 millimeters of mercury. Rescue therapies. Here we found a strong recommendation regarding the use of prone position, which actually should be considered, and for the neuromuscular block, whether no recommendation was found regarding alveolar recruitment or the use of extracranial of extra systems like ECMO or extracorporeal CO2 removal. The risk with these two latter instruments is that they need a high amount of anticoagulation, and in brain injured patients this can cause further bleeding and cerebral complication. Regarding the ventilator weaning and extubation, again, the concept is that you have to consider always the trajectory, the neurological status, the respiratory, all the respiratory factors. However, it's still unclear which is the neurological status which is enough to allow weaning and extubation. So which is the level of GCS which allows us to think that the patient won't fail the extubation. And regarding the tracheostomy should have generally, again, a whole consideration regarding the status, the neurological status and the trajectory of the neurological status of the patient. But the big question which is still ongoing is which is the perfect timing for performing a tracheostomy, early versus late tracheostomy. And in this, the expert did not find a consensus, and we recently published a paper on ICM with a center TBI group, and we found that basically there is a huge variability among centers and country, and this means that probably the guidelines are just local and it depends on local policies and the clinical judgment. The result from this consensus allowed us to write down a scientific agenda, which is extremely busy because, as you can see, there are no evidence at all in this group of patients, and now we need to push forward to answer to all the questions that are still pending in this group of patients. And we hope that the VentiBrain study, which is about to start, we are just waiting for the last details regarding the ethical committee approval. We have 184 centers, and this is going to be a large multi-center observational study where we will aim to assess basically the clinical practice regarding ventilation in brain injured patients and the occurrence of pulmonary complication in these patients. And we will make also some reasoning about subgroups with increased intracranial pressure or with pneumonia and ARDS. While we are waiting for the result of this, I just want to give you some clinical suggestions, clinical recommendations, which are based on the very few evidence that we have, on the consensus that we performed, and on our own clinical practice. So, as I was mentioning, regarding the intubation, consider that brain injured patients need early protection of the airway to prevent aspiration because they have poor neurological outcome, and that they need strict monitoring and targeting of oxygen and CO2. So don't wait too much for the intubation because you risk to have bad side effects. CO2 and oxygen target, avoid hypoxia, but also avoid hyperoxia, excess hyperoxia. Aim generally for normocapnia, and consider that hypercapnia can increase intracranial pressure. Hypocapnia, on the other hand, extreme hypocapnia can worsen cerebral perfusion. Regarding the tidal volume, try to be protective, try to reduce the plateau pressure and to keep the plateau pressure between 18 and 25 and to maintain a low driving pressure, minimizing the respiratory rate. Don't be too scared about the PEEP because if the hemodynamic stability is maintained with the PEEP, probably this won't have a big effect on the intracranial pressure. Recruitment maneuver, consider it case by case. In some cases, they can really help to improve the oxygenation, but again, be very careful with the hemodynamic status of the patient. And the same is for the prone position. It can actually improve oxygenation and it can actually improve cerebral oxygenation, but use it under a strict neuromonitoring. Regarding the other strategies, they should not be forbidden. So consider it case by case and consider the risk of bleeding and the risk of respiratory failure and hypoxia. So in some cases, ECMO has been, for example, used in brain injured patients without the initial bolus of heparin or with a half dose. So this should be considered in a multidisciplinary status. For the extubation, there are not specific scores in this population, taking consideration both respiratory and neurological factors. And for extubation and tracheostomy, try to have a long-term view to consider the neurological performance and trajectory of the patients and the clinical status of the patients. And the timing for tracheostomy, so far, there are not strong indications, so should be according to the local policies. I would like to thank you for your attention, and of course, I'm available for any questions that you want to ask me. Thank you very much.